I'll try to describe this in the most coherent manner I can. Congress passed the Drug Quality and Security Act in 2013. Congress, as part of this legislation, the FDA was charged with the responsibility of developing a memorandum of understanding to be signed by states that would regard the oversight of, I quote, the distribution of inordinate compounded products over state lines. When we look at that, the reason why they asked for the compounding memorandum of understanding is there was a concern with certain compounding pharmacies acting more like drug manufacturers than acting like pharmacies that were creating and preparing drugs that were specific to an individual patient, to their individual needs. What I think everyone here in this room knows is the parenteral nutrition that you get is very specific to you. There are lab draws that are tested for what nutrients you're getting, what you might be deficient in. And so everything that you're getting in that space is very specific to you, and it's compounded to you pursuant to a prescription. So when the draft Memorandum of Understanding came out last year, what it said was dispensing is included as part of the definition of distribution of compounded products. This sounds like a small issue, but it's actually a big issue, and it will be a problem if it isn't fixed. Here's why. When someone like you receives a compounded nutrition product, the pharmacy that provides that to you is licensed in the state that you reside in, but their brick and mortar where they're compounding the product might be in another state. So they're licensed in your state, the State Board of Pharmacy licenses them, and then they take that product over state lines and dispenses it to you. If the Memorandum of Understanding restricted interstate compounded products being dispensed, there could be a big problem with access to these products that you receive if it's coming from a facility that's outside of your state. We've been doing a lot of advocacy on this issue, and actually Joan made it up to the FDA in the June time period to also talk to the FDA about this. But this is a problem that needs to be fixed. But we don't come here to scare you. We come here to want you to leave empowered and be able to be an advocate on these issues. There are solutions to both the FDA compounding issue and the lack of Medicare coverage for home infusion.
As Kendall mentioned, there are solutions. That's the good news about this. One solution comes in the form of a bill, and this bill is currently in the House and the Senate at this time, and it's called the Medicare Home Infusion Site of Care Act of 2015, and the reference number is S275HR605. This is why your voice, your story is so important. You have the power to influence politicians to make a change for the better. This bill, what happens is it will create a reimbursement stream for home infusion providers so that way they can get paid for the services and supplies that they provide for home infusion therapy. Right now, infusion providers only get paid for the drug, nothing else. Personally, I've spoken to several people who've been affected by this bill, this loophole in another way, as to where home infusion providers have refused to accept them as a patient because they had Medicare. So this will help that out as well. Basically, this bill will coordinate coverage between Medicare Part B and Part D by eliminating the loophole. Now, I also want to mention that I was assured by the Senate Committee on Finance that what is currently under Part B, for example, TPN, will remain under Part B. And what's under Part D will stay under Part D, and that there's provisions written in so that way TPN won't transfer under Part D and then have copays and stuff. So together, as an Oley family, we need to raise our voice. We need to get this problem fixed. The Medicare Home Infusion Site of Care Act is a common sense solution. Private insurance companies have known that it is cheaper to provide care within the home environment than within a medical facility, but CMS CMS, the Center for Medicaid and Medicare Services, has not caught on to this yet. And I was told by the Senate Committee on Finance that what we need to do is we need to raise awareness. We need to spread awareness that people can live at home successfully, safely, and at a cheaper cost while on home infusion therapy. Today, I am here speaking with you. I need your help in advocating for awareness. And I also wanted to mention that we are more than our pumps, our tubings, and all the IVs or the enteral nutrition that we're on. We are home pen consumers living our life to the fullest, and that can only happen if we remain in our home environments. Even though I may feel like a dog on a leash at times, my IVs are so much more than that. My IVs give me the energy and the means to live my life and to be me. To me, my IVs are like wings are to an eagle. They allow me to fly and to be free and to live my life. I would feel like a prisoner if I had to live in a nursing home only to get IV infusions. Before I transition back to Kendall, I wanted to mention there are two other bills that are in the House and Senate that might be important to you, and we'll provide more information on those during the breakout sessions. But one is the OPEN Act, and that is a bill that will actually provide incentives to medical companies to repurpose medications that are already approved to treat one condition to get that approved so that way it can treat other conditions. So I know a lot of us may be on medications for off-label use, and that's actually a liability to some doctors, and some doctors won't prescribe them because of that. So this will help with that. Another one is the Functional Gastrointestinal Motility Disorder Act, and this would actually transfer money within the National Institute of Health for more research into functional gastromotility disorders to hopefully find a cure and better treatment.
Now, to talk about our solutions to the compounding MOU, I'm not going to take too much time talking about this because it is a little complicated, but we have things that we can discuss at our session later today in the breakout session, and also at our table over at the NHIA table. But the method to the madness with the FDA is right now they have what's called an open docket, and submitting comments to that open docket is the appropriate way to weigh in with the FDA. So if you're interested in advocating on this issue and how you affect change in this space, please come by and see us later today, and also please come by and stop by the NHIA desk.
One thing I wanted to mention is when I first started with advocacy, I wondered, where do I begin? What do I say? How do you even do it? But the one good thing is with Oley, I got connected with the Digestive Disease National Coalition. And if you get connected with an organization like that, they will actually teach you how to tell your story, how to conduct a legislative meeting, and they also will educate you on the key priorities that are current related to digestive diseases. One other thing is they also offer scholarships to help defray costs, so that's very helpful. For years, I did nothing. Back in the early 90s, doctors told me that there was nothing more that they could do, that this is the way I was going to have to live my life. That maybe in 20 years there would be more out there, a medication or a treatment. Well, it's been over 25 years and there's nothing. So I started thinking, well, what if? And because of that, that's what inspired me to start doing more. As you know, the squeaky wheel gets the grease. Those who are vocal get the funding and the research, the treatment, and possibly even a cure for their disorder. Why leave it to someone else? First, I connected myself with organizations, learned how to lobby. After participating in a legislative meeting, what's very important is to follow up. You need to send a thank you, and then even contact them again with updates and stuff, because it's really building a relationship. That's what matters, and that's what is very helpful. Advocacy starts with sharing your story. You are the expert on yourself and on your condition and on what you've been through. All you need to do is speak from the heart and tell your story. Pair your story with a request. Organizations have on their website usually a list of key priorities related to your condition that are important in politics at this time. And so you just kind of pair it with that. You don't have to travel to DC to lobby. You can make a phone call from home to one of your representatives. You can meet with a representative locally. You can also utilize social media. You can also have a newspaper, TV, radio stations involved in spreading awareness. There's so many different ways. I contacted the Philadelphia Inquirer. I saw that a journalist wrote an article about drug shortages, and she wrote an article about this issue recently, and it was on the cover of the newspaper. What happened, several people contacted me, shared their story, and it inspired me to do more. I wrote a petition, and currently there are 73,000 signatures on the petition in support of this bill, and it's making a difference. Okay.
How many people signed on since you?
The number of congressmen has more than doubled since the petition started in January. So currently there are 71 congressmen, and a quarter of the Senate now sponsors the bill.
72, because we got one this morning.
Yay! What I do is I go on, and then this is where you use social media to thank them and tag them.
Yes.
They love that. What I did want to say is with the petition, when you sign it, a letter goes to your congressman and to both senators, and those letters are making a difference. Last year when I went on the Hill, I was told, you're just one person. In March when I went down, my senator's office told me, we received over 2,300 letters within the last few weeks from people because of this increased interest. It's a numbers game. Yeah. Even though they were form letters, they said, oh, there's increased interest. The very next day, she reached out to Kendall, and later on, they signed on as co-sponsors. So it is making a difference, and what we need to do is we need to get more co-sponsors to make this difference. One of the biggest hurdles is to commit to be an advocate, not with just your mind, but you need to commit with your heart. And the one thing the Oley family has is heart. Your story is powerful. Please sign my petition. Please contact your representatives. I need your help to make this happen, to improve lives for those all across the country on infusion therapy.
And it may seem like a daunting task, but we are here to help you write your letters, get organized for a phone call, to do whatever it is that you want to do. Kendall and the National Home Infusion Association does a wonderful job of putting out information that's understandable. We use most of it and try hard to understand most of it. We still have a little work to do in that area. But there's a cloud of suspicion when industry and government comes together. There's always that one word, profitability, and they will listen to Oley members, I think. We just have a louder voice, and it's the heart that comes through.
This is definitely an effort in teamwork. This is something to actually give you a little bit of background on myself. The reason why I'm involved in this issue is I worked for the American Diabetes Association, and this issue came across my desk when I was their policy director. So this is something Oley's involved in. We're working with the American Diabetes Association. The Cystic Fibrosis Foundation is involved. And it's not one of these situations where a industry who I represent in this space, the providers, we're definitely working hand in hand on this one, where I don't see a nexus where there would be suspicion of our industry. We want to do this so we can service this community, and we feel very strongly that we can get this done this year.
So it isn't a Joan Bishop, it isn't a Kendall Van Poel voice, it's a Betty Bond, and it is your voice. I can't emphasize that enough.
Yeah.
And there are going to be a breakout session, and there's also a table, the Home Infusion Association, and So if anybody has any comments that they want to make now, we'll take a couple. But there's other venues where you can learn more about this.
If you were not here last evening, I just want to reinforce Betty. She won the Advocacy Award, and you can see why. And I know many of you will... Many of you will say, oh, my home infusion company should be the one writing. I shouldn't be the one writing. But you know what the feds say? Yeah, the home infusion company has something to gain financially by this. You don't.
Right.
You have
you're
your
the
life
most,
to gain.
You're the one that they need to hear
right.
from. Yeah.
Contact them.
They definitely want to hear from the people that are the consumers of the service, because it matters the most to you.
Oh my goodness, during some of the legislative meetings, I've actually, now I always try to hide my pumps and tubings, but I pulled them out and I showed them, and they look and they listen. Now sometimes you do run across somebody that, you know, is kind of like a wall, but that's where you work on building a relationship, and it does make a difference. It's amazing. And then it just kind of empowers you to do more.
I would just want to mention that, Betty, we ran the Philadelphia Inquirer article in the newsletter. There are a few copies on one of the tables out here. We have some newsletters and Oley materials in case you're not familiar with them. But it's also on our website, so if you wanted to read that article, you can find it on our website.
I want to commend you, Bettemarie, for your advocacy. I too have been advocating against INFIT because of the fact that there are loopholes. And those loopholes are those of us who blenderize, and also the fact that just as the loophole should put you in a nursing home, that loophole can put thousands of feeding tube users into nursing homes also, because as you know, INFIT requires 2 hands to connect. We are losing our slip joint connector when we go to the through-threaded INFIT connectors, and I really do appreciate your constant efforts to overcome that loophole. And I know a lot of people here look down upon me because of my constant fight against INFIT, but we have to advocate for ourselves. I do not want to go from being a 3-year feeding tube user to becoming a TPN patient. And just as the doctor pointed out in his previous talk, green beans help your digestion, and so does a breakfast like I had. I had walnuts, I had blueberries, strawberries, oatmeal, a cup of coffee, and a couple of other items in my morning blend.
Thank you very much for your comments. I think there's one more question up front.
I just wanted to say I'm Liz Tucker with the Short Bowel Syndrome Cure Project, and we have some examples at our table of what you can, write to your to let them know.
Fantastic,
So
fantastic. So stop at that table too.
And I'll piggyback on that Oley last summer actually worked on some letters as well. So on the Oley website, it directs you to the person. If your congressman wants to sign on to the letter, it tells them who they need to contact, whether it's the House or the Senate. They make it really easy. All you have to do is add a blurb about your own personal story. So.
Thank you, everyone.
Thank you.
We could have kept going.
Whoops.
I'm hearing that Dr. Ng is just parking his car, so we have a few minutes.
One of the things I could say just real fast, I kind of held off on it for the sake of time, but I did want to say after this session at the NHIA table, we are going to be setting up a camera, And if you want to tell your story about the lack of coverage for home infusion or how the FDA Memorandum of Understanding could affect you, please come by. We're going to take those stories, we're going to put them into some advocacy materials that we can share with your member of Congress. So if you feel inclined, that's an avenue that you can take today.
Thank you very much, Kendall. So why don't we stretch our legs for a couple minutes while we wait for Dr. Ng. Okay, folks, we're ready to move ahead with the program. If everybody wants to sit down, we'll have plenty of time to chat with each other all day.
And it's worth the wait.
Yeah, so it's definitely worth the wait. We now have Dr. Ng with us. Dr. Ng is the chief of the Division of Cardiology and the co-director of the Heart Institute at the Children's Hospital in Los Angeles. He is an interventional cardiologist and professor of clinical pediatrics, and he is here to talk to us a little bit about venous rehabilitation and the management of your occluded veins that you have to deal with because of your catheters. Welcome, Dr. Ring.
Well, thank you very much for inviting me to give this talk. I wasn't sure exactly what the background everybody who's here, but my lecture here is really about venous reconstructions. And when I first started doing this, it was really based on our cardiac patients who undergo a lot of cardiac catheterizations and would need surgery and they would need access to their vessels for IVs and so forth. And some of the kids who get multiple operations procedures end up losing their vessels. And of course, many of them don't have any symptoms until you go in to try to put an IV in and you realize the veins are clotted off. So early in my career, we came up with a way to actually reconstruct or recannulate some of these occluded vessels. Now, I work at the Children's Hospital Los Angeles, which is part of USC. And in the last few years, I've discovered actually that there are more patients besides cardiac patients who need this. And so we've sort of expanded this to other areas. And one of the areas that I got very involved with was the GI service with a lot of their short gut patients who need chronic TPN and loss of vascular access. I'll show an example where I got involved, and it was upon that particular case that led me to realize that there are a lot more patients who have these problems and needs that has not been addressed in the arena of the interventional, either radiology or cardiology. So I titled this lecture, Venous Rehabilitation, Changing the Paradigm in the Management of Occluded Veins. Now, here's the problem. Many of us at various points, as either practitioners or as patients or parents of patients, have encountered a situation where there's a vascular access issue. Either the IV is blown, and you either yourself as a practitioner have come across that, or parents or the child or patients, or you can't begin an IV because you just can't find something, or the line has thrombosed and that has to be removed. Usually what happens is that the solution for that is you take out the IV and you can try again until you can, and then you call the specialist, the PIC team. And then there's a fair number of experts who does this all day long in hospitals. They'll come into your floor and maybe put a little anesthetic on your arms, or you'll find wherever you can find and put a line in there. And that's fine until that runs out. And as long as you can find another line of a vessel to put a PIC line in, you're fine. And then you go on to managing your primary diseases, and the patients go through their hospitalization and course. Well, what happens when the PIC team cannot find access? Then what? Of course, that happens too. And then you call the surgeons in, and they'll put in a central line. They'll either put a Broviac or Hickman or some sort of a surgical procedure where you put an IV in so that you have some ability to either get blood or give medicines or use or give TPN or etc. So of course that happens, and you're fine moving along with your treatment of primary disease until they can't find a central access. Then what? Then by that point, all of your veins are gone and you're really stuck. Now again, I know that there are patients who have needs that need chronic IV access, that this becomes a problem further and further down the line as you lose more and more of those superficial vessels. So when we are in the cath lab or in the interventional radiologist suite, when you lose one femoral vein, the natural paradigm is we'll go to the other side, and we do that. When both sides are gone, you might then go to the internal jugular vein. What happens when both are gone and both femorals are gone? Now you're really stuck, right? You may go transhepatic, and we've done that too. We can't get to the heart, we'll stick a needle into the liver and go into the hepatic veins and go from there into the IVC and get into the heart that way. We can get very creative in getting access. What happens when the veins are too small for larger delivery systems? Or you need dual access. Now again, that's more particular to certain procedures, but the idea is that sometimes you need more than one open vein. What happens if you have an infection and you can't leave a line in permanently? So at some point, the patient run out of venous access or develop signs and symptoms of venous insufficiency. You lose all those vessels, blood has to get back out of your extremity somewhere, and so sometimes the blood gets stuck in the vessels and can't get out, and your legs, your arms can swell. So out of necessity for access, we've learned that we can actually recannulate some of these occluded vessels In fact, we wonder whether we shouldn't be doing this prophylactically. If you lose a vein, rather than say, let's just go to the next vein and wait for that clotted vein to thrombose and scar down, where in the future you may not even have an ability to open it up, why not try to do this prophylactically? Take care of it while you know it's still a fresh clot that you can get rid of. So that's really the paradigm shift that we're trying to get people to think about, especially in patients who need chronic IV access. So, oops, I think, am I right? Yeah. So what does this apply to? You either have patients who don't have any symptoms but need central access, or chronic indwelling lines, but they have run out of venous access. Patients usually with chronic diseases, short gut syndrome, the premature infant who needs IV access until they're big enough, cystic fibrosis patients, various patients who just got chronic disease, hem-onc patients, etc. So you also have the congenital heart patients, right? We talked about premature infants, patients who need TPN or chronic IV access in short gut, cystic fibrosis, hem-onc patients. Or now the other group are patients who have symptoms. In other words, they have a known vessel that's occluded, but it's a big vessel and the body can't get the venous blood back to the body, and the limbs swell. We call this either SVC syndrome or IVC syndrome. And these are symptomatic. And those, I'll show you examples of what I mean by that. Patients who've got thrombophilic diseases, patients who have various types of diseases where they tend to clot very easily. And so what happens there is that they'll have a clot, and the clot gets exaggerated, and over a longer period of time, the whole vessel gets lost, and then they just don't have a way to adequately return blood back to the heart from the limbs, and they swell up. And I'll show you examples of that. So these are thrombophilic. This is more in the hematology thrombotic patients. So what I think is that the problem is this. It's not a problem until it becomes a problem, but when that happens, it becomes a big problem. And I saw this picture, and it really reminds me of what at that state. You know, you're trying to take a good picture, and by the time you realize this bull 12 inches from you, it's a big problem, right? So we don't want to get to that situation. So here are some examples. Now I'm going to break it down to blood vessels that are occluded from above and blood vessels occluded from below. So these are the infradiaphragmatic venous obstructions. See that you can have a femoral vein that's clotted off. You can have an iliac vein that's clotted off. You can have an IVC that's clotted off distally down below. You can have something that's more higher up. You can have bilateral combinations of IVC, iliacs, and even proximal IVC. That's right before it enters into the heart. So you see all these areas can have clots, and of course you can imagine the blood has a hard time getting back into the heart for the normal circulation. So the most commonly encountered issues that I found is the femoral veins, because that's the very common place where we go in for access. Again, these are patients who have got chronic disease, a history of multiple chronic femoral venous access. There are patients who've had indwelling lines for a long time, especially when they started as a young baby, especially in the premature babies. Clinical signs of that obstruction really depends on the location and the extent of that obstruction, whether it's acute or chronic. If it happens acutely, the body can't make new vessels to get blood to return. But if it happens chronically, they can develop collaterals. But the collaterals don't usually keep up with the normal flow. Think of LA traffic. If you get blocked on a highway, what do? You find an exit and you go off the exit and you go off through local streets and get back on the highway later on. That's what the body does. They'll make collaterals, but you can never be as efficient if you can go down the main highway. It also depends on whether there's adequate venous collaterals, and that's what I mean by those side vessels that the body will make. Oftentimes, if this happens early on, the patient's actually very asymptomatic because the body has been able to build all these side vessels to get blood back to the heart. Except when you try to get in, you can't get in. And it happened very early in life. So here's an example of the supradiaphragmatic. This is what's coming from above, from the head down to the heart. You can see that this SVC baffle is totally occluded. In fact, I don't have a pointer on this, do I? Guess not. Okay, you can see that there's a red arrow there. That's where the obstruction is. So again, you see how the blood here can't make its way down into the heart, so it goes back through this other large vessel heading down posteriorly. Again, here's an innominate vein. This is the blood that's draining from your left arm that's getting back to the heart. See how it's almost totally gone. So you can imagine that the blood from the left arm is going to have a hard time getting back to the heart, and it'll swell up. This patient actually has subclavian veins. Again, we use these for PICC lines, right? Subclavian veins gone in this patient. This patient actually has internal jugular veins that are gone. Again, red arrows point to you where the obstructions. See all those little wormy-looking vessels? That's the body's trying to make its way, get the blood back in. Of course, it's not as efficient as a major highway, but the body's trying to get the blood in. It's just not adequate. So the head will just swell up. This is what we call SVC syndrome. So patients with thrombophilic syndromes who clot easily, there's a patient who's got a long segment. It goes from the legs all the way up to the diaphragm where the heart is. The entire vessel is gone. So blood has a hard time getting back into the heart. Now again, they have multiple collaterals to try to make its way up there, but it's not efficient. They tend to have very swollen limbs. This patient has a clot in the subclavian vein. You see the arm, this is the right arm, and the blood just can't get back into the heart because it's clotted off. Here's another example. Patient with factor V Leiden syndrome. Now these are syndromes that you just clot very easily. So the patient didn't know this until for many years, until you see how the blood vessel just totally clotted off, and the body finds ways to get up there in a very inefficient way. My best example is really LA traffic, because that's where I have to encounter this every day. Oh, perfect, thank you. Is it working? Yeah, I'm pushing all of them. I can see it red, but it does not shine. Sorry. So the most commonly are the SVC obstructions, that they tend to have lots of symptoms. Again, we see patients with chronic congenital heart disease who've had surgery where their lines are put in the IJ or the subclavian. Those patients can have clotted off SVCs. Patients who have transvenous pacemakers. You put a pacemaker from your arm into the innominate vein, it gets in the heart. Well, that wire over time can also cause that vessel to clot off. There's a special types of heart disease where you have transposition, where the great vessels are inverted, and those patients can also, after surgery, develop occlusions of those areas. Patients who've got chronic indwelling lines, especially in the IJ and the subclavian area. Premature infants, those requiring TPN. Clinical signs of venous obstruction are SVC. The whole upper body is going to be swollen. They just don't feel good. And the blood just gets backed up into the head. They'll have headaches. They can't bend down, et cetera, et cetera. And they involve multiple vessels, both right and left side. They tend to be chronic. And if it's a single vessel, sometimes they are asymptomatic because they're collaterals. And I'll show you examples of that. So what are the indications? The absolute indications if the venous return is compromised. In other words, the arm is totally obstructed and there's swelling and you don't feel good. And in those situations, you have to do something about it. They could be acute or they could be chronic. And they tend to be very long segments, not just one short area. It's a long area where the vessels are occluded. You see IBC syndrome, where the lower extremity loses the flow back into the heart, and they tend to have liver swells up, the legs swell up, the kidneys don't work as well because blood can't get back into the body, into the heart. SVC, often seen in infants. Vascular access, or when vascular access is absolutely needed. Again, in kids with short gut syndrome is one of the big ones. I'll leave some of these other very specific lesions out of the discussion because these are more congenital heart patients. But again, with patients with transvenous pacemakers, their head and arm can swell up because they clotted off the main vessels. This is the one that you guys are all more interested in, patients who've got chronic lesions who need IV access over a lifetime or many years. There are some relative indications, and that is usually the patients who don't have symptoms, but they have adequate collateral flow. Why is that a relative indication? It's good until you need access, and of course by that point you don't get it anymore. So if you know it's occluded, just because you don't have any symptoms doesn't mean you shouldn't try to take care of it ahead of time. Just think of the time when you're like running low on oil. You can still run for a long time until you're empty of oil. Now your car is totally dead, right? So you don't want to wait till that far out. So it usually involves superficial vessels, and the femoral veins is one of the more common places where you lose those vessels. And again, the legs look perfectly normal, but if you know it's occluded, think of fixing it before it becomes a problem and you need it. Or when you know a patient needs to go to surgery and they'll need some central lines, or for cardiac catheterization, where you depend on the femorals as the primary way to get the catheter into the heart. And let's see here, convenient, desirable, but not absolutely needed. Again, you guys all can think of situations where you would like to have your veins open so you can get blood drawn, right? You don't want to get stuck 5-6 times because they couldn't find a vein. So here's a recent case. Now again, to me, this was the case that actually got me thinking about how this goes beyond cardiac patient. This was a 5-year-old girl, ex-preemie, had NEC, necrotizing enterocolitis. So as a result, the surgeon took a lot of gut away. So she had short gut syndrome. She needed TPN for probably all of her life. So she had multiple line infections, and she slowly lost vessel one at a time. She had one remaining PICC line in the left IJ, and that became infected. So the physician, knowing that there were not much vessels, they actually tried to treat her through the infection for 2 weeks on antibiotics, and no matter what, they couldn't clear the infection. The only way to clear the infection is to remove that line. But you can picture, once you remove that line, you've gone, you've lost everything. And we know that patients with short gut syndrome, the highest morbidity mortality is when they lose all the vascular access. So here's the example of the right femoral vein where you can see that blood doesn't get back into the body, into the IVC. It's just totally gone. So the whole thing is very long segment narrowing there. In fact, there's an area in the yellow arrow where you can see that there's no flow at all. In fact, the contrast is where we trying to push through this vessel that's occluded. You see some of the stain of the contrast. And this is showing you how we do this. And here's the other side, the left femoral vein, tiny little beak there that shows where the vessel is occluded. See all those other very wormy looking vessels? That's the way the body tries to get back into the heart. Again, not very efficient, but that's the only thing the body has to get blood back to the heart. So we're sort of trying to make our way up to the inside of the vessels, up towards the heart. And again, finally, we get to a part where you can see some normal flow up on top at 12 o'clock. See now the flow is much more brisk. But we made our way through this whole long segment of occlusion. And with that, we're able to start taking little balloons and stretching it out. And again, who knows how long this has been occluded? I suspect this happened when she was a baby. But you can see how we can use gradually bigger and bigger balloon. And now you see there's much better flow going up to the IVC, the inferior vena cava. And so finally, at this point, remember the kid has an infection. We can't really put a lot of things in there. So basically, we put a new line in there. We removed the old line from the left IJ. So now at least she has a line that we can use to give TPN and give antibiotics. The infected line was removed. Of course, I couldn't put any stents in there because I know that if I put a stent in there, there's still a risk of having an infection on those. So we sort of put a line in as a temporizing measure. But and look how long this area of loss of vessels is. There's 157 centimeters of occlusion. And so 21 days later, after the antibiotic treatment and the infectious disease expert says, okay, she is infection-free now. We bring her back to the cath lab. You can see the area where the previous PICC line was put in. That area is occluded completely. So now you see the innominate vein. Now that's the vein that drains the left side of the head back to the heart. See how it's totally gone, right? There's no blood there. So we're making our way out there, and finally we see there's a tiny little remnant vessel connecting the two. Again, that's where the old line was. Of course, that's gone now because it was pulled 21 days ago. But if you left it alone, that's going to scar down, and you'll forever lose that left IJ for future access. But what we end up doing was that we end up recannulizing that. So you see how the left IJ is tiny. It's like the thread. That's the remnant of what he had left from the line. And so we're able to actually recannulate that. It's hard for me to see from where I'm standing, but you can get to see how I'm pushing it. Oh yeah, there it is. Thank you. So you can see how I'm coming from the left IJ, and I'm coming from the femoral vein where I was able to recannulate that 21 days before, and we're trying to have them two meet each other. So eventually, we're able to pass a little tiny wire through that occluded vessel, and I take a snare, and I actually grab that vessel. Now I have control of both sides. Now I can pull it all the way through. So now I have a way to get a wire from the occlusion all the way down to the legs. And with that, I'm able to run the sheath up, and here you see me passing a balloon in there, and then we're going to inflate this and try to open up that vessel. Again, these take a lot of work, but it's very rewarding at the end. So you see how we're passing that wire up there, and let's see here. Now we're ballooning this up and down the vessel, again, starting with very small balloons. Then we gradually use bigger balloons, and over time, you're just stretching this vessel out and reconstituting what it used to be, the bigger balloons. And then eventually, we can see that there is a connection now. Right? Before, there was absolutely no connection. Now, this is still not enough, because those vessels will just scar back down if you leave it alone. But because she still need a line, we then put a new PICC line in there. So this is a new PICC line coming from the IJ. Remember, that was the side that had the infection. That's clear now, but it was totally gone. We recanalized it, put that new line in this, and now we go back and say, okay, so we've got that taken care of, at least for now. We're going to go stent the femorals, because we want another access in case she comes back with an infection. We have to have a way of getting another line in to treat the infection. So now, because we no longer have a PICC line in the femorals, we're going to stent this. So we put 1 stent in, 2 stents in, 3 stents in, 4 stents in, and now see how it looks. That's what it's supposed to look like. That's what we all have. But remember how it looked like before. You didn't have any flow in there, and you had all these little tortuous vessels, but you've reconstructed this. Now you can actually use this again for the future. Now, I'm sure that she lost this when she was a baby. She's 5 years old, and had we thought about this 5 years ago, we might have been able to fix this by just removing the clot and not have to do this at all. But now at least we've been able to gain access to the right side. So so that's just that example. So afterwards, I actually went back in and restented the left IJ, right IJ. So now she has new 3 out of the 4 extremities have ways to get access. Again, she's 5 years old. She's got short gut. She's going to need that line for a long, long time. And it's nice to have some plan Bs if your plan A doesn't work. So now just to show you that this is a 5-month-old baby who didn't really have a lot of symptoms. Now, she had heart disease, but you can see how this vessel here on the lateral, the little beak there, that vessel doesn't go anywhere. But I know that when I take a picture there and I see that little tiny beak, I know that I can get through that. So again, that just tells me that if I see this early enough, I can find that I can get through. If you wait long enough, that beak may go away, and once it goes away, I can't get in. So that's why if you know that the vessel is gone, rather than say she's fine, let's leave her alone, use that opportunity, that window, to try to fix it before it becomes a problem later on. And that's the paradigm I'm trying to get people to think through as a shift in how you think about vessel access. Here's a side view. So see how the red arrow points to the little beak? That's the remnant vessel. The one behind that is really not the vessel. It's the collateral flow. It's not the main highway. That's where the main highway ought to be. So of course, we can go after this example of the same kid. We're able to find ways of find little wires to pass it right through, and we get back to the vessel where you can, on this panel here, right far on your right, you see that the sheath is now up in the vessel. Now everything's wide open, and of course, that's what we want to put stents in to open it up to that size. And so this is, you can see the AP view. Here's the lateral view of that same little beak, and you see how we make our way back up into the femoral vessels. And of course, this patient also had other problems that needed some interventions, and had a narrowing in the pulmonary arteries, and we stented that, or ballooned that. And here we are putting stents in the femorals. 1 stent, 2 stent. You see how the lateral, see the red arrow is actually where the occlusion was before, and you see the picture next to it. That's the spot that we've opened up. So that area where the longer red arrow is really where the true vessel is, and that was missing on the beforehand. So you see how you can actually reconstruct this, recannulate this, and then put stents in and re-establish flow for future use. 4 months later, we went back in, and you can see that the vessel is nicely open. We actually use that vessel to go and do more interventions on the baby's heart. But without that, we wouldn't be able to do that. So another patient with a SVC now. So again, you see how it's very narrowed down. This one didn't totally get obstructed, but it's narrowed. And patients like this can have a very swollen head because just blood just can't get out of the head very easily. Just imagine if I put you upside down for a while. Your head don't feel very good. Well, patients like that feel that way all the time because the blood can't get out of the head. So we can open that up. So again, you see how that over even 6 to 18 months, this vessel that we've stented remained open, and you can use it again and again and again. So again, there's sometimes the beak is very subtle, and you can see how that there's a tiny little beak, and you have to go frame by frame to figure out where that beak is, and you got to be very careful in looking at it. Now, this is more technical, and for those of you who are not in this field, that might not be as crucial, but I give this talk to my practitioners as well. So for the families, you can see the secrets that I have in my trade. Anyway, so you see that little beak there, and that's how long the area of narrowing is, and so we're able to reconstruct the same patient going from a tiny little beak to a full vessel that we can use for the future. The beak sometimes cannot be seen on AP, but on the lateral projections, again, we use many projections to look for that beak. You see a very subtle little beak there, and then you see how that little dotted line is really where the true vessel should be, but because that was gone, the body made this sort of U-shaped vessel to find its way back up there. And you see how we put the stent in. See the same dotted line, that's where the stents are. And now you have two pathways to get blood back out of the legs into the heart. So again, it could look like this. This is a patient who's got lots of collaterals. And if you slow down the frames, you find one little frame where you see that beak on the two views, AP and lateral projections. And you see how this patient actually had the whole occlusion from the femorals to the iliacs all the way up to the IVC with the renal veins. This is where the kidneys drain its blood back in. And you see how that we're able to balloon the whole area, start the stents at that level of the renal veins. And in fact, this patient ended up having 7 stents all along the course from the renal veins all the way down to the legs. This is what it looks like. So very extensive work, but it's very satisfying to see this. Now the baby can actually have vessels that can drain normally. 14-year-old, again, patient. I have plenty of examples. I should probably cut back. I was told I had 20 minutes. I think I'm going to go past that. Am I allowed? Okay. All right, so here's a patient who has a Fontana. Again, these are patients with very complex heart disease with a single ventricle. Obviously, these kids need a lot of help. And if we find these kind of problems where the IVC is gone. See, again, see how the blood vessel just can't find its way up there. It's totally gone. And you can imagine the kids don't feel very good because the legs are always swollen. And so you see how we end up where the vessel coming back up into the heart is severely narrowed down. So we end up advancing tooth sheaths there, one for both sides. And you see how this patient also had a coarctation. We had to fix that as well. So these kids can have multiple vessel problems. So we fixed some of the vessels, we'll pass this, and then now we're stenting in IVC, stent 1, stent 2, and now we get down to the bifurcation. One goes to the right, one goes to the left, and we actually put 2 of them at the same time, and you can actually reconstruct everything into the pathways that it's supposed to have. Sometimes this patient had a heart transplant, and you know that the heart transplants have to have biopsies all the time. So if you lost a vessel, it's going to be really hard to get back into the heart to get those biopsies. And so this is an 8-month-old baby who had a heart transplant. The whole vessel was very narrowed down. We ended up putting a bunch of stents in. Now, unfortunately, if there's not enough blood return adequately, those stents will clot off. So in this case, you see how we come back, the stent is totally clotted off. But the fact that there's metal there allows me to know that there's a target I can go after. So no matter what, even if it's clotted off, I can still get there and get inside the vessel to get to the heart because I have a target to work with, because I can see the metal on the x-ray. Whereas if you don't, it's a blind stick. So again, this patient had 9 biopsies over 5 years, and as she grew, the stent went further and further into her pelvis. But because I have a target, I can use a lot. And this needle is like, 12 inches where we had to go through and get in there. But we're able to get in. We always worry, but we're okay. We start off with very thin wires, and if you perforate with a thin wire, the bleeding is going to stop. So I don't worry about big bleeding. Just like if they poke you and they hit your blood vessel, and but they pull out the IV. So it's going to be a small amount of bleeding. That could happen. But that's why we start off with very small wires first. Yeah, so it's a great question. The question was if you have a stent in place and later on you have an infection, can you have a problem? Well, the body takes 2 months to 2 to 6 months to endothelialize. Usually by the end of 2 months, the body has already formed a lining over it. So it's no different from the lining of the other vessels. So yeah, within the first 6 weeks, we pay attention. But afterwards, the stent is totally inside the wall. But that's a great question. So in this case, over 5 years, we just went further and further. Again, she needs her cardiac biopsy. So if you don't do this, you're kind of stuck. So we're able to utilize this. All right, so coming from, now there are some tricks that we have. We can't find it from below. We can actually put it from above, and you see how if you're stuck from below, you can actually put a catheter through the IJ, come all the way down to the legs, and take a picture from the other side. If you have an exit point, you at least have a target to know where to go. So you can see how if I did that, I'm able to aim my needle against that other catheter to know where to point it to. So again, these are little tricks to know that I don't extravasate. I don't go outside of the blood vessel. And with that, I'm able to get back. You can also use the other side. So if one side is occluded, the side is open, I can go from one side, come around the bifurcation, get to the other side. And you can see how that's where the catheter is. I can take pictures. I can use that as a target and find my way out there. And so you see how eventually I'm able to open it all the way up. Again, this had a long segment on the right side. We're able to take that needle and wire, aim it against the catheter that is positioned on the distal end, and we're able to open that up. And this patient now has a stent. That's the bladder in the middle. That's just a contrast that was used. The body will filter that into the bladder. So that's what you're seeing there. So sometimes, as I said, the stents can reocclude, but because there's a target in the metal, I can go back in and balloon things, and I can still open it back up later on. So here's a patient who's got factor V Leiden. It's very easy to see that one leg is thicker than the other. Now this kid was a baseball player, and he just thought that because he was working out, he worked out his right leg more than his left leg. We know that's not the case because he's got the factor V Leiden where he clots very easy. So he probably lost the major vein from the right leg for a long time. So here's the patient now. You see how the blood has nowhere to go. In fact, you see some little clots sitting inside that vessel. These are old clots, thrombosed down, and blood just can't make its way. So the body can't get the blood out adequately, and guess what? The leg swells. In fact, he noticed that that's happened as he was going through his puberty growth. That makes sense, right? Your body makes these collaterals. It's fine until you start growing your extremities, and you're going through puberty. Your legs are getting longer, and the body just doesn't have enough time and cannot keep up with the growth of the legs and with the collateral flow. So of course his legs started swelling. It's also when he was doing weights, so he thought that was because he was doing weightlifting, but it doesn't make sense to have one leg bigger than the other. So here you see that this whole area is gone. And in fact, the other side is pretty gone too, except the other side has a bigger collateral. So his other leg wasn't as bad, but this is one of these thrombophilic syndromes that some of our kids will have. And as an adult, you guys heard about DVTs, right? Deep vein thrombosis. It's the same kind of mechanism.
Study to see if in fact serious veins are being lost.
Well, I mean, if there's
wait a minute. And second, the question would be, you know, if I do have to go through this, and my line is going to be put somewhere else for a time, they want to know how soon they can go back to using that recanalized vein. And they do need to know the question that Dr. Mikulik asked, which is, what are my risks of infection with having that particular metal in me?
Okay, so let me just answer. I've done this for 20 years. We've never had a stent infection, all right? So it's 0 right now. Now, as I said, the first 6 weeks, 8 weeks is when you're highly at risk. So therefore, that's the time when you want the body to heal it as well as it can. Once it's endothelialized, like any foreign body that's put in the body for any type of medical procedure, it gets healed. If you were to look inside that with pathology, you won't even see the metal because it's inside the wall of the vessel already. So that's why I have to emphasize that infection is a risk for the first about 6 weeks, 8 weeks. After that, it's not a big deal anymore because it's part of the wall. So that's number one. Number two, if you don't have any symptoms and if you no need for chronic veins, I'm not advocating to go have a procedure. That would be silly. These are for chronic disease patients who you anticipate needing vessels.
Your audience, a great proportion of them are dependent on a vein that they can use, and they're going to be dependent indefinitely. So the question for them is, am I in trouble, and should I be doing something prophylactic, or should I just wait until it happens?
Well, that's the paradigm, right? If you say, I know that over a long time, your doctor's going to tell you, you don't have an IJ. I have to go to the left IJ. You lose that. I have to. So if you're finding you're moving down that pathway where you need more and more expertise to try to find vessels to put lines in, you know you're heading in that direction. So you want to take a chance and say, look, I'll wait till I get my infection. that's the risk you take. If you know this in advance and you're trying to plan this out, then you can try to fix it. Now, keep in mind, if you don't have any symptoms, it usually means your body has the collateral vessels, right? That's what it means. Now, if you're already fully grown and you don't have symptoms, I doubt that you're going to grow any more so that your collaterals need to be caught up. A patient like this who had symptoms, he was asymptomatic until he went through his pubertal growth. So during that growth phase, the collaterals just can't keep up. So when that happens, you're a little stuck. Now, keep in mind that if you have a fresh clot, let's say you have an IV and you have a problem, you do an ultrasound, they say there's a thrombus sitting in there. If there's no symptoms, you can leave it alone, but that thrombus is going to get fibrosed down. It's going to become a scar. It takes a lot more work to deal with a scarred down vessel than a fresh clot. I can remove a clot by using thrombectomy. I'll show you examples of how you deal with acute occlusions. This is more chronic occlusions. But if it's a fresh clot, you can suck it out. You can have, I'll show you a device called the angiojet where you can actually remove the clot to avoid the whole fibrosis part. I hope that helps. But those are great questions. I think that this is very relevant to...
Sorry, but going back to Dr. Howard's question, and let me just give you the quick case. I had a PICC line for 6 years in and out in my left arm. I was off TPN for 4 years. Okay, they come back, they go, all the veins are blocked. They have no access on the left, so I had to go to the right. Okay, so the question is, I've got on my right arm now, I've got it, I'm going through the same vein, but how do I keep something from happening so 5 years from now, right? And it's been nice, they've been able to they pull now and replace over the wire, which has helped. But what do I do now? Am I proactive now to take a look so I don't have the same problem on my right arm and the other veins later?
Well, ultrasound is the least invasive way of looking at your patency of the vessels, right? If they're patent, then there's nothing to worry about. If they're telling you they're clots, you can get this fixed and before it becomes worse.
But the problem is you don't, how do you, I don't have a doctor or somebody who's going to do that. Well, I have to make my own appointments, right, to get the lines replaced. Nobody's managing that.
Well, that's why this is a new paradigm. This is not something everybody's doing. We're doing this as one of the, again, this is new science. This is not something that is all standardized around the country. There's only 2 or 3 centers that are actually doing this kind of stuff. But I wanted to introduce this as ideas that you guys, if you take it back to your centers, you might be able to be an advocate for your interventional radiologists to be more aggressive at looking at this. Again, this is not something that everybody's doing. So I'm not saying that you know, even if they are able to diagnose it, they may not be able to do this. But this is new science. That's why I call this a paradigm shift. It's not something that everybody's thinking of.
Is there like a point of no return for these young adult patients that have had chronic TPN their entire lives and maybe 75% of their veins are blocked, maybe out of the 6 access points, 4 or even 50%, 3 are blocked? Is there a certain year timeline where you feel like you can't go back in and try to recanalize because you're saying that scarring down is much harder to do than taking out the clot?
Well, I don't know if there is a specific time to say this is the point of return. When I discover this, when patients are referred to me for this, I do my best to recanalize it. I would say that with the beak, there may be a 70% success rate of getting past through this. But the point of no return is when you can't get through, and or you extravasate and you stop. Because once you're outside the vessels, there's no point in trying to push yourself. So there is no time limit. This patient was 19 years old, and he's probably had this for a lot longer than immediate. So, you know, I think that the best chance is in the beginning when the clot is fresh. It doesn't take long before the clot starts to get organized by the body and becomes fibrotic. But we're talking about weeks to months as a window to get rid of it.
Okay.
Yes.
So you said there are 2 facilities that does what you do. What are the 2 places?
Well, okay, so the other place I know does this very routinely is at Texas Children's, because I was there. I started that program there.
So these are a lot of pediatric. Is there like an adult place?
Yeah.
Or
I don't know all the adult facilities that do this. I don't. When I look at the literature, there's not a lot of work published on this.
so how do we? Do you have copies or anything that we can give to our doctors? So like when this does happen to us, we can say, go to this conference, learn how to do this procedure?
This is so new that there's a lot of people who are just being, I mean, in fact, these are the things that I get asked to go give talks on at some of the medical meetings because this is so, people aren't even thinking about it. That's why the paradigm is that now, when you lose a vessel, they just go to the next vessel, right? But there are certain patients who, at some point, you lose everything, and then you don't have them. That's why you really got to be very proactive in saying, is there a way to fix this?
Do you have a copy of your slideshow that we can give to our doctor?
Somebody just asked me that earlier. I will put, I mean, I have patient names on somewhere in the bottom, so I don't want to give out HIPAA violations. I'll get into trouble. But I'll put together at least a PDF file so you can see some of this.
And maybe
yeah.
where you're speaking, other places you're speaking at or doing conferences?
I'm sorry?
And places that you do like conferences and talks, so we can tell our doctors to go to that?
Well, I mean, these are all, most of what I do is in cardiology. So if they want to go to one lecture for the whole conference, that's fine. But they're all pretty common. You look, the major conferences will have some of these kinds of discussions.
When the slides are finalized, they'll be available on www.oley.org. So under conferences, we have all the presentations.
Hi, I had a question. So how does a patient get access to you, or how does a doctor make a referral? What do the patients do? I can think of one patient in my mind who would benefit probably from something like this. How does someone go about getting this treatment if they live in a non-metropolitan area with these problems?
I don't know how to answer that in a very thorough way. I mean, I'm happy to give you an email or contact so you can find me. But I know that we've seen patients from out of state. The ones who are pretty web savvy can figure this part out, and I'll get contacts and I'll get a call and I'll see them in clinic and work this out. But it's not, I mean, I don't go advertising my services. I work in my children's hospital and I do what comes through. What I'm excited about is that there are ways to open this up. Right now, I would say the majority of the medical field don't think that they can fix these kinds of things. But there are ways to fix it as long as you are, I mean, these take a long time to put together. These are usually 4 to 6 hour cases. Once you get them in, everything's fine. But it takes that long to just get through those blockages.
And I'd like to say, I mentioned earlier the resource on the web that we'll be working on, Find a Clinician. This could be one of the questions we asked of the clinicians, so it'll be easier to search and identify the centers who have the expertise.
There's a question back there.
Yeah, just a question about trying to avoid getting into this situation. One of the decisions we have to make constantly with our daughter is, do you keep a line longer or do you replace it? Do you have anything to say about is putting new lines in going to result in needing procedures like this, or should you try to keep a line longer? Is one more risky than the other?
Well, I mean, replacing it doesn't necessarily change how the body reacts to that foreign body. I think that part of the process of clot is that you have a foreign body and the body's trying to react to that. Whether you take it out and change it, it won't change it. What you need to do is do the ultrasound, look for clots. If you see the clots, that clot's not going to go away if you have a line in there. You got to proactively remove that clot, or at least open up the vessel so that the clot doesn't continue on to form an occlusion. So I don't think changing the line is the answer. Fixing what is there is really more the answer.
I had a question. I've had a line in for over 25 years, and when they went to put my last line in, the university hospital recommended a certain study, but the local hospital wasn't able to do that type of MR venogram, I think, of the chest. So they just did an ultrasound, but the ultrasound didn't show any of the narrowings that they came across when they were then trying to put. What type of study would you recommend needs to be done? Like, what is the study called that?
Well, this is an angiogram. So we start with ultrasounds, and again, I would totally agree with you that ultrasounds don't find everything. If you have a swollen limb, the ultrasound, if it says it's patent, something doesn't match, right? So you know that just because they actually, a lot of times, I think the ultrasound cannot identify, they might identify a collateral vessel that is moving in the same direction. They might say, oh yeah, it looks patent, but they're actually not looking at the real vessel. They're looking at the side vessel. So that's why ultrasound doesn't tell the whole story. Again, I don't have a good answer for how to fix everybody's vessels. And again, this is so new that this is really more getting the word out that just because you have a clotted line or a clotted vessel doesn't mean you should give up on that vessel.
Thank you for thinking that way. Thank you so much.
You're welcome.
Doctor?
Yes.
Hi, I have a question and a comment. I'll do the comment first. For anybody who is wondering about resources for access, there is this legendary person called Gail Egan, and she is somebody, and again, legendary, that if you don't have access, she seems to be able to do that. She was here last night. I'm sorry she's not here today, so maybe she could answer some of those questions. But if you want to Google Gail Egan, or if you are in that situation, if you're a physician, if you're a patient, that's a resource. Secondly, my question, in somebody who has, say, a catheter still in their subclavian, would you be able to see collateralized veins through the skin, or would you have to do ultrasound?
Well, actually, that's a really good question. I actually have some examples to say if there is obstruction, whether it's true obstruction, total or stenosis, the body's going to make vessels, and a lot of the times you'll see the tiny veins on the surface of the skin. The body's trying to find a way to get past those obstructions, and that's what happens. That, for those vessels that are on the surface will get engorged. You'll see the vessels underneath the skin. So those are little clues that shows that, yeah, maybe there's an obstruction somewhere. You just don't know. But the gold standard is to do the angiogram, so you can actually see the whole vessel along its course. Yes.
Just a quick question, because I have a son, he's had his line, I guess, 6 years now, and he's 12 going to 13, and he's been complaining of headaches. I've noticed swelling, and he's saying his whole body's aching and not really thinking, I'm just getting ibuprofen. Is that something like symptoms, I guess you could say, or?
Where's his line?
It's a central line, and it's.
Is it by the IVC subclavian?
Right,
Yeah.
and he's
Again,
had
I can't answer that based on
But
simple
I'm just
description.
saying, like those type of symptoms, is it something that I should maybe question now, because I just assumed that, didn't really think of it, but because he's having these symptoms of headaches every day, maybe I should ask my
It's
doctor
possible.
about that. Right.
This is where I think nowadays, you have angiograms, you can have CT scans. Sometimes we actually will have a patient who's had a CT scan somewhere, and you can clearly see where the obstruction is. So CTs can work. MRIs can be very helpful. So they're more than just ultrasound. I think there's a hand up there.
We're very thankful for CHLA, and I was just wondering though, for the CHLA patients, is it hematology that refers to you, or is it GI, or is it kind of just, you know what I mean? Like, how do they get to you if the child does have clots repeatedly?
So it comes to multiple ways.
Okay.
I mean, so if you have a factor V Leiden and you're going to be seen by the hematology service, they know I'm around, so they'll find me. The GI guys will call me, the NIC. So yeah, I get multi-directional points of contact. Sometimes I'll get an email from somebody who found my email on the CHLA website and say, so I've had somebody who actually contacted me from Nevada, and just, I heard you can do this, and yeah, come on over. So we took care of that kid.
Now, is this recommended for patients with MTHFR? Like if they have.
What's MTHFR?
It's a blood clotting disorder.
Yeah.
Yes.
I mean, those are the kinds of patients that end up having these kinds of problems. Okay. Obviously, you have to work in a connection with the hematologist, because also picture this, they have you on blood thinners, right? But if the vessel is clotted off, that medicine can't even get into the vessel. So you have to have a combination of mechanically opening up so that there's blood that can get through there so the medicine can get in there to work.
Yes.
So we have to work in partnership with the hematologist as well.
Thank you.
Yeah. Well, I didn't realize there was that much interest in this. Should I continue or stop?
I think we're good.
Okay.
I'll let people come
Okay.
to you later. Yeah, these people rely on central veins for their existence for the most part that are on TPN, so this is hugely important to them. So we're going to let Dr. Ng finish, but if you want to catch up with him later, please feel free to do so. Joan, you have any other comments? Okay, we're moving ahead with the, whatever you call it. corporate awards.
Can I have Oley board members please come up to the stage? Yes, please. Good morning. I'm Rosalind Dahl, and I'm on the Oley staff. One of my responsibilities is to fundraise for this great organization so that programming like this is free of charge for patients. We are eternally grateful to our many friends in industry. Without their support, we would not be able to hold this conference. We wouldn't be able to put out the Lifeline letter, have the website, all the different services that Oley offers to patients. We are especially thankful for our corporate partners who provide Oley support all year round, not just at this meeting. Partners exhibits are indicated by blue ribbons. So when you see one of these on the exhibitors, please say thank you for your year-round support. When you see an exhibit that doesn't have one, you might ask them why they're not supporting Oley. You can also thank them for supporting this meeting, though, because even just in coming to the meeting, it's wonderful that they do. As a token of our appreciation, we'd like to recognize these corporate partners. And as partners, I'm going to ask you to come forward as your company is announced and remain up front for a group photo over here. So you can come this way, grab your award, grab your ribbon, and stand over there. When do they shake our hands? They shake your hands as they come up. And Joan, if you could come forward and hand out the awards, that would be fabulous. Okay. So, drum roll, please. We're starting at the patron level partners, and these are partners who provide $5,000 to $9,000 every year. We have Applied Medical Technology, Apria Healthcare, Excelicare, Cook Medical, Functional Formularies, NutriShare Canada, Real Food Blends, and Teleflex. Next, we have benefactor level partners, and these provide $10,000 to $19,000 each year. We can please say a warm welcome to Abbott Nutrition, Nestle Health Science, and Option Care. Next, we have the Bronze Star Partners who give between $20,000 and $29,000 every year. That list includes Baxter International, Fresenius Kabi, Halyard Health, and Medtronic. next group are the Silver Circle Partners, who provide between $30,000 and $49,000 each year. BioScript Inc., Coram CVS Specialty Infusion Services, and NutriShare. The next level is Gold Medallion Partner, and these partners give between $50,000 and $69,000 each year, and we have one partner at this level. It's Thrive RX. And new this year, we have a donor, Shire, that has stepped up their commitment and become a platinum partner, giving $70,000 to Oley programs, as well as support for other programs. Many things at this conference you'll find. In addition to thanking Shire, we'd like to invite Shire to say a few words.
Good afternoon. My name is Karen Ruth, and I'm the Director of Patient Advocacy at Shire. We are proud to continue our support for the Oley Foundation and your community. Shire is committed to becoming a leading global biotech, delivering innovative medicines for rare diseases and specialty conditions. We are thrilled to be a part of this meeting as we take inspiration from you, the patients, caregivers, your families, and your entire healthcare team, as well as the Oley Foundation. Please visit us next door and share with us your stories and learn more. Thanks, and have a great meeting.
And I've just noticed one of our partners has stepped into the room, BioScript. If you could come forward, Trish. Lisa, have you taken the group photo yet? You got, oh, can you guys get closer together? That'd be awesome. Okay, and then I'd like to call forward Joy McVeigh-Hugick. Do I have that right? And she's going to say a few words of thanks.
Thank you, Roz. On behalf of the home parenteral and enteral nutrition community, it's my honor to thank you for your corporate sponsorship. Because of your substantial year-round giving, Oley is able to fulfill its mission of enriching the lives of people IV and tube-fed at home through education, advocacy, and networking. I find it amazing that Oley is able to put on such a content-rich and multi-day conference experience free of charge to consumers and families. Without your generous support, a conference like this would not be possible. Personally, I can say that attending my first Oley conference last summer was life-changing. It gave me the added confidence I needed to blossom and grow as a consumer and as an advocate for our community. You see, even though I've been on nutrition support for over 5.5 years, I only attended my first Oley conference last summer. I'm not completely sure why. There are lots of reasons I shared last night, but I think at the end of the day, I really just needed to come to grips with my new normal and accept the extent of my condition. And one of the ways that I did that was by attending my first Oley conference. Before the conference, I rarely fed in public. I'd plan my schedule around my feeding, so I just wouldn't leave the house for 15 to 18 hours, because that's how long I usually feed for, or I'd disconnect early, and I deprive myself of very needed nutrition. But like I said, attending Oley was life-changing, and it gave me an opportunity to connect with other consumers, caregivers, clinicians, and corporate sponsors like you all. And that's what really stood out to me. I'd been to lots of professional meetings before, but the unrestricted access that we're given as consumers to talk to the people that make our feeding tubes or our formula, as well as their competitors, so that we could make informed decisions on our care. That's just amazing to me. So I very much value the chance to speak with incredibly knowledgeable dietitians from home infusion companies, or the people that design and work on developing new products from the manufacturers. And Oley creates a synergistic environment that I don't know that I've seen anywhere else, ever. So something else that I cherish is, while monetary support is obviously what's needed to keep an organization like this going, the human support that your organizations provide to me as an ambassador is incredible. So whether it's helping me connect someone across the country to a local rep because they're having trouble with their tube, troubleshooting on different dietitian issue or diet issues because of your people, that makes all the difference for us, and it's a tremendous resource. You know, Oley does a lot with a little, and your continued support is critical to the success of this organization and all of the people it supports. So thank you so much, all of you and your organizations, for what you do.
Thank you again for all you do. So you're welcome to join us for lunch and in the exhibit hall to see all these great products and services. Pick up an exhibitor scorecard if you haven't at registration. I understand the conference bags have arrived, so you can pick up a bag as well. They come in different colors. Enjoy. Thank you.